All right, good afternoon, everybody, and welcome to this evening's or afternoon's Professional Education Quickenar, our COVID-19 event. My name is Matt McDonough. I am with the ESRD NCC, and on behalf of the NCC and CMS, I would like to welcome you to this afternoon's event. Before we proceed, I do want to make a note that this evening's session is being recorded and will be published for viewing at a later date on our website, which we'll provide later in the event. So let's quickly cover our agenda this evening. First, we'll be talking a little bit about what this call is about. If you've been on these calls before, you probably know, but we'll give you a background on what this call is all about. And then I will take an opportunity to introduce today's speaker, Dr. Tushar Chopra. His topic today is Pathways of Managing Home Dialysis Patients During the Era of COVID-19. And everybody's line, if you're connected today, is muted, but we do want to hear your questions and comments. If you have any questions for our speaker today, please use the Q&A panel, which is available from your WebEx menu, or the chat panel to submit your questions for our speakers. As time allows, near the end of our event, we will pull selected questions, or all of them, if we have time, and ask those questions and hopefully get them answered for you before the conclusion of our event today. So this call, if you've been on these calls, again, you may already know this, but these calls are an opportunity for us to hear from stakeholders and peers that are in the ESRD community who are adapting to the challenges and the obstacles that are being presented by COVID-19. Our speakers and our guests share examples and provide real-world strategies for facilities to hopefully use in their day-to-day operations. And these are a weekly series of calls, and the topics do vary week by week. So we do hope that if you enjoy this one, you will come back for a future event. So without further ado, I would like to introduce Dr. Tushar Chopra. He's the Medical Director of the University of Virginia Staunton Dialysis Unit in Staunton, Virginia. Dr. Chopra is also an Assistant Professor of Medicine in the Division of Nephrology at the University of Virginia Health System. He serves on the National Kidney Foundation of Virginia Medical Advisory Board and is a member of Mid-Atlantic Renal Coalition, ESRD Network 5's Medical Review Board. It is my pleasure to introduce and to turn the event over to Dr. Chopra.
Thank you, Matt, and thank you everyone for giving me this opportunity and taking time at 5 o'clock to attend this Quickenar. I just wanted to know how I would advance the slides. It would just...
Dr. Chopra, I'm happy to do that for you.
Oh, that would be great. Thank you. If we go to the next slide, Matt, I would like to start. Why are we talking about home dialysis during the COVID-19 era? Is because we all have to adapt to the new normal that we have, and home dialysis becomes very important in this era because we all know the advantages of choosing peritoneal dialysis, which is autonomy to the patient and better lifestyle and improved quality of care and access-related advantages that we have. But in COVID-19, there is lesser exposure to the home dialysis patient, to in-center facilities or the hospital, and that may be one of the reasons we need to present to our patients in the COVID-19 era who are in the CKD clinic or who are transitioning towards the dialysis modality on top of all the known advantages that we know of home hemodialysis or peritoneal dialysis. Next slide, please. So here I have tried to summarize some of the pathways to increase comfort in managing a kidney disease or a home dialysis patient during these times. I have divided them into pre-end-stage renal disease and then what happens in the hospital, and finally what we are doing with in-center patients. And this is our experience in University of Virginia. For the pre-end-stage renal disease, which is the CKD clinic, we used to have an in-person options talk where the dietitian, the social worker, the nurses collaborated together and gave like a 1.5 to 2 hour long lecture about kidney diet, employment and insurance, treatment options, how transplant was working. We are trying to make it all virtual, like we have Quickenars, but we are making short videos. The key is if we have a very long video of 2 hours, it will be very difficult to engage the audience, and we are trying to divide them into shorter videos of different subdivisions like peritoneal dialysis, home hemodialysis, transplant, diet, and conservative management. So that's one thing we all should definitely do, is a virtual education curriculum, which can be available publicly on the organization's website, on YouTube. Social media can have a very big impact with virtual education, and it will probably be far more than the in-person options talk that we were giving to a certain group of patients who were attending with their families in a closed environment. So this is definitely positive, and it will have an impact even after the COVID era. Next, coming to access. Again, we all know that CMS has clarified the importance of access placement being essential procedure, because it is necessary for the survival of the end-stage renal disease patient, which includes peritoneal dialysis, intravenous catheters, AV fistulas, AV grafts. The key is, if someone does not have an access, they deserve an access. If someone needs interventions to keep their dialysis going, then we must communicate with the interventional radiologist or surgeons to try and get those accesses done. There may be a two-way communication between the nephrologist and the systems that you're in to discuss the pros and cons in the context of COVID-19, and they will be reasonable. I also have mentioned over here endovascular AV fistulas. We do have the capability of endovascular AV fistulas at UVA, and I wanted to give you all, this is a technique of percutaneous AV fistula that can be done by a nephrologist, interventional radiologist, transplant surgeon could do it. It requires the regional anesthesia or local anesthesia. It uses veins in the proximal forearm. For example, the ulnar artery to the ulnar vein, or the radial artery to the perforator vein. So you save a lot of the other veins that are available for the patient. There was an endovascular AV fistula study which showed 90% patency at 1 year, reduced hospitalizations and reduced interventions in patients who got endovascular AV fistulas. There are a lot of advantages to this newly developing technology, and if the systems that you all are working in, it would be nice to talk to the interventional radiologist or nephrologist or surgeon, whether they are trained or equipped to do these procedures, because you would get away from general anesthesia, which is a risk factor in a dialysis patient, and this could be expedited in patients that have difficult accesses. For example, ulnar artery to ulnar vein is not usually stuck, so those veins are preserved. So that is something we are doing with our interventional radiology folks. Coming to hospital starts. Now, hospital AKI is quite common. 20% of COVID-19 patients are getting acute kidney injury. And it is important to understand that they're going to be in the ICU and they are critically ill with, acute respiratory distress syndrome. In those circumstances, CRRT is the treatment of choice. What I have highlighted over here are the mild to moderate cases that are probably on the floor with minimum oxygen requirements. They're not in the ICU. And I wanted to highlight how home dialysis modalities could be of use, especially in a resource-limited setting where we have seen in New York and Louisiana, where they ran out of cartridges and they ran out of CRT machines, and they had to do acute PD and urgent start PD on some of them. We have used home hemodialysis machines. We have incorporated our home hemodialysis machines for SLED as well as nocturnal hemodialysis, and I will come to that in the next slide in details. But the last thing that I wanted to talk about was telemedicine. We are all very well versed with telemedicine, and I'm sure we are troubleshooting telemedicine every day, but this is definitely something that may remain with us after the COVID era. And lastly, we'll talk a little bit about management of a PD patient with COVID-19 and how nursing home PD could be an option during this time. Matt, could you please get me the next slide, please? Thank you. So these were the hospital starts AKI patients, and urgent start PD, most people in America know how to do this. Urgent start PD is normally done on a CKD5 patient that is going to be on end-stage renal disease, but it can also be done as acute kidney injury in a resource-limited setting when you don't have nurses or you don't have CRT machines or hemodialysis machines. So after you have exhausted everything, acute PD can happen. Important to discuss is who is going to be the person that is going to place the catheter, where the catheter is going to be placed. It would be advisable to place the catheter by the bedside, but some surgeons would prefer to take them to the OR for laparoscopy. That is dependent on the surgeon. The tricky part with acute PD and trying to get patients on PD while dealing with acute kidney injury and COVID-19, we don't have reimbursement for a PD patient who develops AKI like we have for hemodialysis. So a lot of the providers are de-incentivized to put them on PD even though it is totally feasible and okay to do, because they won't have an incentive to do so as opposed to what they would do with a hemodialysis patient. So there is some sort of improvement needed in that aspect. Short daily is something which we would do in a stable patient where CRT machines are exhausted, and what we are doing is intermittent renal replacement therapy, which is prolonged with home hemo machines. And you could do it with next stage, you could do it with tableaus, you could do it with any machine that your system has that is approved for home therapies. And we have in UVA, we have two protocols. We are using the tableaus with either in a stable patient, we give them at least 4 to 6 hours of treatment 4 times a week. And in an unstable patient, we reduce the blood flow rate. We give them at least 6 to 8 hours of treatment 5 times a week. So if they are sicker, we just reduce the blood flow rate to mimic it like SLED. Nocturnal hemodialysis is definitely something you want to consider in a patient who needs to do rehab. They need to get out of the ventilator. So their daytime is occupied in getting well from COVID. So an option to give to your intensivist is we will do the dialysis at night so that during the day you can work with them, try to extubate them, try to do as much physical therapy, just physiotherapy they can get. So definitely keep these modalities in mind, and once the patient is better, they have at least experienced the benefits of these modalities in terms of blood pressure control, phosphorus control, medication burden. Next slide, please. So urgent start PD, this is just a quick update. PD catheter placement, bowel prep, if at all possible, pre-op antibiotics. We try to get them a purse string suture as well as fibrin glue in the tract to prevent leaks. I start with a low volume supine CCPD in a COVID patient because there is going to be increased intra-abdominal pressure whenever you put PD fluid in the abdomen, and that may impair ventilation. You're not supposed to do it in a COVID patient who is on prone ventilation and if they have very high oxygen requirements. But if this is the last therapy that's available, you could start with low volume, and the data for acute kidney injury NPD comes from South America, and it was done in non-COVID patients. It was done in patients with malaria and other reasons for acute kidney injury. They used high volume supine CCPD. But I wouldn't recommend starting off with high volume. Start off with low volume and move to high volume as tolerated. Next slide, please. Telemedicine. Now, everyone out here is adapting to telemedicine, and we all know the advantages that it is improving access to our patients. It improves their quality of life. It could be a cost-effective modality. There are fewer ER visits, hospitalizations, and it is helping us keep our patients safe at home by preventing them from coming to our visits over here. There are certain disadvantages that are listed here. It does not integrate with EMR. There are some privacy concerns. and there is lack of outcome data. CMS has been remarkable in pushing with the COVID times and has initiated these waivers. For example, for PD, the initial 3-month face-to-face MCP visit post-dialysis initiation, then the face-to-face MCP visit once every 3 months. And we don't know how long these waivers would last after the COVID-19 crisis is over, but definitely these are welcomed by the renal community. Next slide, please. So this is the management of a home dialysis patient with COVID in the ICU. So if someone is on peritoneal dialysis or home hemodialysis, and if they are in ARDS, then the treatment of choice is to do CRRT. We'd start them on CVVH, which is hemofiltration, and it is a hypothetical concept of removing larger molecules and cytokines because they get the cytokine storm. And anticoagulation will invariably be needed in all of them because they're so hypercoagulable. So all our protocols of CVVH have anticoagulation inbuilt in them. There are programs in the country that are using heparin and citrate together because the patients are so procoagulant. Data regarding pathophysiology and outcome will probably come by next year, but CVVH is theoretical basis of being better in larger molecule removal. CVVHD can also happen, but we always start with CVVH. If you've exhausted your CRT options, then you have to think of prolonged intermittent renal replacement therapy with the home machines like I outlined. It's because the resources are limited. You could use 2 machines for 4 patients. And lastly is acute PD, where you would do supine, CCPD, which is cycler, every 1 to 2 hours, start low volume, and increase as tolerated. Next slide, please. This is what you would do on the floor. If this is a PD patient who comes and gets admitted because of COVID-19, you don't need to switch modality. They are stable. They're not in the ICU. They are oxygenating appropriately at 2 liters or 3 liters. You can continue their prescription like it is, but maximize on fluid removal. So out here I have listed strategies of fluid removal in somebody who is on ambulatory CAPD and has residual renal function. Then maximize on the diuretics. They still pee. So try to maximize on diuretics while using hypertonic dialysate because you want more volume off. And if you have to increase the fill volume, do it at only 200 ml increments, because if you increase the fill volume that is dependent on body size, it will increase the intra-abdominal pressure. But if you increase it in 200 ml increments, the intra-abdominal pressure is not remarkably increased. Similar concept, if you don't have residual renal function, you would not use diuretics and you would use hypertonic dialysate and increase fill volumes. In CCPD, which is cycler, we use the daytime. We try to use day dwells to maximize on our water removal and salt removal. You want to avoid the long day dwells because all the glucose gets absorbed, and try doing a midday exchange. So, and in the last column, I have written strategies on what should be done to the cycler prescription based on the transport status. Next slide, please. So in summary, what I want to focus on, we want to, this is my biased opinion that I'm more home dialysis centric, but you have to keep in mind the patient and patient choice and what fits best for the patient. But we need to be a little bit more home dialysis centric. Acute PD for AKI should have coverage by insurance because there should be equality amongst all modalities. And assist PD coverage will also help because the nursing home patients can stay at the nursing home, and if they are staying at the nursing home and not going out, then we should have ways of dialyzing them in the nursing home through assist PD. And we want to get away from this in-centric, hemocentric attitude. And that's why I've written the downward arrow for that. But that's my talk, and thank you for listening to me.
Dr. Chopra. Thank you so much. And before we do jump into the questions, and we've received a couple, we do encourage you, if you have any questions for Dr. Chopra, to please use the chat panel or the Q&A panel to submit them. But we have received 2 or 3, and we tend to get a few more as we start to answer them. So let me ask you the first question that came in. What is your suggestion on performing any due PETs or adequacy collections on PD patients who are in a nursing home during this? They don't have any signs or symptoms of uremia or fluid overload at this point.
Right. So we are trying to minimize any unnecessary testing. So the PET test, the traditional PET test can be waived. Modified PET tests are available, which can come when they're given the PD fluid for the adequacy testing. Even the adequacy testing need not happen every 3 months. We have moved it further. The home visits by the dialysis nurse is also being done virtually, if at all possible. We want to lessen the exposure of the home PD nurse in going to anybody's homes to protect all patients as well as staff.
Great. Robin, I hope that answers your question. Thank you, Dr. Chopra. Another question that just came in. Have you seen a shift in the types of patients that are referred for home dialysis now that this COVID-19 environment is here?
Yes, and yes and no, actually. Because, like I said, it all depends on who is taking care of the patient and how comfortable they are in managing which modality. Peritoneal dialysis, I do think the newer generation of nephrologists are going to be very well trained and equipped with managing acute PD or urgent start PD. This used to happen in the past. I mean, senior nephrologists have probably placed acute PD catheters, and they placed a straight PD catheter by the bedside, but then at some point it phased away. So there is like a dichotomy in people who have done a lot of PD. That being said, we all learn from each other, and having a mix of both providers on service is going to help in maximizing the right thing to be done for the patient.
Very good, very good. Another question came in. Have you seen a shift in some of you obviously on your last slide said you're very home dialysis centric and pushing that forward. Have you seen any shift in your colleagues that have not been as home advocacy forward as you've been?
Yes, there has been a shift for sure. Because, well, it's all about level of the nephrologist. We have done a lot of educational series and seminars to improve the comfort level amongst fellows and nephrologists to make all options available to patients.
And I guess a tack-on question to that is if there's a shift that's happening or it's becoming more received more, do you have or do you provide usually any recommended resources for colleagues or other nephrologists that are less comfortable with home dialysis but are obviously more interested because of the situation that we're in?
There are a lot of resources available for dialysis curriculum. ISPD has a dialysis curriculum which is online. The Home Dialysis University happens in America, where a lot of training nephrologists go once a year to do quick 2 to 3 day sessions. There are separate ones that happen for faculty. Within institutions, we are developing online educational curriculum to be in tune with the millennials, with education being on mobile apps and everything being available like PowerPoints and slides and papers and questions, all the education material in an app form. So that way you could study on the go and all the answers should be on the mobile phone. So Developing mobile-friendly educational tools will definitely go a long way in making all of America comfortable with home dialysis modalities.
Great, great. And looks like we have one more question, unless we have one that's going to come in last minute. Um, this question is, are home patients who've been hospitalized during COVID-19, are they able to return to their home treatment plan after hospitalization, or how easily are they able to return to their home treatment plan? And do you have any recommendations on how best to handle this transition?
Could you repeat the question again?
Sure. If a patient's hospitalized during COVID-19, a home patient is hospitalized, um, how quickly and how easily can they return to their home treatment plan after they've been hospitalized? And do you have any recommendations for how to handle that?
Right. So if it was mild to moderate COVID, they definitely can go back to their home treatment plan, just trying to keep them a little bit more net negative. It is the ICU patient that has had a very aggressive form of ARDS, and their recovery is going to be prolonged. They will probably go to a transitional care hospital and undergo more rehab. And if they were on PD, then you have to think of switching modalities. And transitions between modalities should preferably be home to home. So you can take the home machine to a transitional care hospital too and do home dialysis over there. That would require buy-in from the staff at the transitional care hospitals. And we would have to work with the systems to do that. But that's the only transition I can think if there is a prolonged recovery time from the pulmonary standpoint.
Very good, very good. And we did get one last question that came in, and I think we have time. Do you have any visibility to contact tracing with home patients who have tested positive for COVID?
So contact tracing is going to, we are doing contact tracing and trying to get them tested. What we are not doing is testing, we're not doing antibody testing. But there are apps out there for contact tracing. We're not using that. We're working with the Public Health Department in collaboration for contact tracing.
Okay. Well, Dr. Chopra, that wraps up our questions. I just want to thank you again for taking the time to be with us this afternoon, and appreciate your time, your presentation, and your answering our questions today.
Thank you, Matt, and thank you, everyone, for this opportunity.
You're very welcome. Thank you so much. We're going to go ahead and move into our conclusion. Before we do that, we do want to talk a little bit about the kidneyhub.org. You may have heard us talk about this a little bit. This is a new resource developed by the ESRD NCC, along with assistance from our subject matter experts, our patient subject matter experts. It is a mobile-friendly, secure tool, and it is housing resources such as COVID-19 emergency resources, as well as patient-created resources on transplant, infection prevention, etc. It is constantly being updated. It has been updated with the educational materials for new and experienced ESRD patients, and it's being consistently enhanced. So if you have a moment on your smart device, whether it be a smartphone or a tablet, take a moment, go out to thekidneyhub.org, and take a look around and let us know what you think. So our next COVID-19 Quick and Our events, these save the dates are here for you to hopefully be in attendance on our next events. Our next patient-focused event is May 19th, 2020. That is at 5 p.m. Eastern Time, just like this one was. And our next provider-focused event is 1 week from today, 5 p.m. Eastern Time. Those events are on our website and available for registration now. That website is www.kidneycovidinfocenter.com. You can visit that site for more information on each of those events and to register for those and future events. And also, our archived events from the past are online there. Our recordings and slides from previous events can be accessed at that website as well. So on behalf of the NCC, I want to thank you for your time this evening. Our contact information, if you'd like to get in touch with us, is on the screen here. Our website is esrdncc.org. We've also have some additional COVID-19 resources available for patients and providers. Our CASER Coalition website is on your screen. And again, our Kidney COVID Info Center COVID-19 hub, kidneycovidinfocenter.com, is available directly from that URL, and we encourage you to take a moment and go out and visit that site as well. So thank you for your time and your attention this evening, and we hope to see you on our events next week. Thanks again, and have a great evening.